I'm Dr. Ellie Zarale. I'm a plastic surgeon. I work at the Gender Confirmation Center here in San Francisco. And I offer trans femme bottom surgery along with other things. But just a little bit of background, as you know, or you can deduce from what I just said, that I'm one of the few surgeons who have actually, that I dedicate my whole career to gender surgery now, and I'm one of the few surgeons that have gone through the process firsthand. So I feel like I'm very privileged to be able to be in this position and help others go through what at one point in my life, someone helped me get through. So I wanted to sort of provide the same level of not just expertise, but also kindness and the support that I got from the surgical team that I went to as I went through it. And so, I think the GCC, we try our best to kind of make that process as smooth as possible. But having said that, there are certain requirements, especially when it comes to insurance. In general, I do follow WPATH standards of care. Now it's version 8, and I feel like version 8 left a lot of sort of open-end interpretation more than it did before. I recently tried looking up something and I just couldn't nail down a specific thing. And so I just started texting other surgeons that I know, asking what their individual policies are. And that was specifically, which I'll go over in just a bit, the letters for bottom surgery. So yes, I do require a letter. Of course, SOC 8 as opposed to SOC 7 has to be 2 letters, and the person who wrote it needed to be like a psychologist or an MD. They had to have certain credentials. And now they changed it so that any provider who's gender competent and has been treating the patient for a certain period of time, that their support letter would count to fulfill that path requirement. So yes, I do need a letter, and the person that writes that letter, and this is where I had that question that I had to reach out to other places of how long does that person have to have known you, right? What's the history behind the treatment for gender dysphoria from this provider? And currently mine is 9 months of a history of they just saw you for the first time and now they're writing you the letter to recommend, surgery. I think that's not the right thing. And so I think an established provider-patient relationship should be established. And the responses I got from different places, basically, a lot of them were like 1 year, 1 full year. And I feel like, and that's fine because everybody sets their own limits, but mine is 9 months. And we do look at the letters. I think once, I'm old enough now that, there's a lot of virtual therapy places now, and you can get online and sort of get a letter almost right away. So that's not really the intended purpose of these recommendations. So we do look at them, and we don't, we don't want to flag a very generic one that doesn't match the interaction that we've had with a patient in terms of their history and, even the patient, I guess, sort of behavior or anything like that, or things that they say during the consultation. And so we just want to make sure that being taken care of, you're getting the right kind of care from that mental health branch of the multidisciplinary team that, allows this to be done safely, right? So I'm only the surgical part of things. And so I do have to rely on the other branches to provide the medical care, right, with the hormones and other things. And then the mental health providers to help the patients, not just with the gender dysphoria, but anything else in the mental health. So, but one of the things I always tell patients is that just because SOC came out last year and their recommendation is down to 1, a lot of insurances are lagging behind in what they require in order to proceed with surgery. So sometimes they're stuck on the two letters, and they will basically not approve your surgery unless you provide them with that. And so to that, I just say, rather than trying to fight it, because they're the ones paying the bill, right? They're the ones covering these very expensive surgeries. And just go with it, And then the second letter, that can be just like the old SOC. The second letter was really a confirmation letter, and that one could be like a one-off. Sometimes, again, depending on the interaction of the provider with the patient, even on the mental health part, they want to meet with a patient more than once before they even write that confirmation letter. So if that's the case and that's what they require, then obviously go with it. Then you're just responsible for, whatever your copay is or your deductible, meeting your deductible and things like that. And
Can I
so
hop in
that's
real quick for a quick question?
sure.
So when you're talking about the two different letters, it sounds like what you're saying is for you getting the approval for surgery from you specifically, you only really need one, but for insurance, you would need two.
If they
What
require
credential?
it.
Yeah, for most of the insurance that would require two, what credentials would the provider need to have in order to give you that surgery for approval? Is it someone who was like your PCP? Is it someone who was like your behavioral health there or like behavior therapist or like a psychiatrist? Yeah.
I mean, for me, the second one can be any of them. It's no different than the first one in terms of the qualifications of the provider.
Okay. And then what would the other one have to be then if it's regarding insurance?
Well, the same thing. It's same for both is what I'm saying. So the first one is the one that's been established, right? Established care. And the second one, if that's what they want, at least my requirements. I don't know if you know any different, Rosie, that the second one is just a confirmation letter and they don't really discriminate between specialties of the providers. Is that right, Rosie?
Yeah, sometimes there are some insurances that do want both letters to be written by a mental health provider, a licensed mental health provider. The majority of them, though, are fine with at least one letter written by a mental health provider and then the other one written by a medical provider or a hormone provider.
Okay. Yeah, so it really depends. And so, some people are like, well, I have Blue Cross. So it's like, okay, or whatever, any kind of insurance, X insurance, but everybody's policies are different. And, most of the time is provided through their work and sort of what package they get. And so sometimes there are exclusions to certain types of gender surgery. This is something that, I'm dealing with probably every month in terms of like denials, appeals, and then I have to get on the phone with the insurance company for these what they call peer-to-peer phone calls about a certain denial, and I try to like convince them to or explain to them why I'm asking for this procedure. And so anyway, it's hard to basically fight the insurance. We do try, and like I said, I'm easily a month at least. I'm doing one or more peer-to-peer appeal calls, and many times they say this patient's policy specifically does not include coverage of X procedure, and at that point, there's nothing I can say. They're just going strictly by the book, and so it's really frustrating doing these calls. So anyway, so that's the letter requirement for surgery. And then moving on to other things in terms of eligibility, and some of these aren't necessarily policy or administrative. I think there's a lot of other things that go onto it. And so I separated these things into different categories, and I'll go through this. I'll talk about weight requirements. I'll talk about health, comorbidities, and things like that. Other things that also need to be addressed going into consultation, but also going towards a surgery. Let's talk about the comorbidities, right? If someone's healthy, then it's easy, but many of our patients, young and old, it doesn't matter, have other comorbidities. And just as an example, a frequent one get asked about is that I have like colitis, right? Ulcerative colitis or Crohn's disease. That's just an example of a comorbidity, right? And is that going to get in the way of having bottom surgery? And the answer is no, but hopefully that patient is being treated for these comorbidities and they are under whether it's blood pressure, whether it's diabetes. So our team does look at medical history and anything that may play into the safety and the success of the surgery and anesthesia. So in part, we also, although we're not the anesthesiologists, we want to make sure that our patients are able to tolerate anesthesia. And so we just want to make sure that we obtain clearances. That's what these medical clearances are. And without them. So unfortunately, some of that falls onto the patient in terms of getting the providers to give us the records because you have to sign off. They can't just like give us your information, right? It's a HIPAA thing. And so we do look at all those things and we just want you to be in your best health going into it. So having a comorbidity doesn't exclude you from having surgery. So that's one thing. The other thing, too, that we look at are obviously medications, but I want to talk about things like smoking, and of course, drugs. Drugs, everybody knows drugs are bad. But let's talk about smoking first before I get into drugs. And you'll see if you log back on to look at the slide deck, it kind of breaks it down. So smoking, right? It's common knowledge, I feel, that smoking is not good for you and it affects people differently. And so why is it important to recommend to patients to stop smoking, especially for any surgery, really, but very, very specifically when it comes to vaginoplasty, and it doesn't really matter what type of vaginoplasty lining, like canal lining it is, that tissue has to survive in that space that the surgeon opened up. Talking about the lining of it. So that lining is really counting on basically sort of like osmosis to live in its first hours, couple days. That's how that graft stays alive and it doesn't just turn black and fall off. And so I have a slide of like the effects of smoking and what it does to the cardiovascular system, but specifically, and not just could say smoking's bad for you. The causes, what smoking causes in nicotine is it makes the small blood vessels, right, the peripheral sort of end vessels sort of shrink and contract and be tighter. And so that's the thing, you don't want to compromise the take of the graft because you didn't stop smoking prior to surgery. My rule is 4 weeks. I recently, just not even about this talk or getting ready for it, just I was having dinner with a colleague and the smoking thing for some reason came up. And they reserve the right to test patients on the day of surgery for tobacco levels or something. And if it doesn't pass, they will not proceed with the surgery. So I don't do that. I do put the responsibility onto the patient. So, it's I can't police everyone, and I don't know. So, but that it goes to that extreme for some of the practices in terms of the smoking part. I just really want patients to be in their best health and go into such a big, complex procedure, having the best chance of success and to minimize the complications. And so smoking those things, but I didn't want to just say it, so I showed a chart or graphs of like how the whole grafting process works, which is how vaginoplasties function. The only exception is intestinal vaginoplasties. Those come with their own blood supply. So that's the exception to that. Drugs, of course, same thing. Drugs are bad for you. And so, when it comes to marijuana, it's legal. It has many known and documented health benefits, but I don't want my patients smoking it because the act of sort of burning and the combustion releases a lot of chemicals. And so for those patients, they can turn to edibles for that and not, sort of go through this period of for whatever they were using it for. Hopefully that ties the patients over for the marijuana use. But I've had one case that I can think of at one of the hospitals here, a vaginoplasty patient who was unfortunately sort of not themselves. They were pretty aggressive, just very poor behavior on the day of surgery in the pre-op area, and something was off. And so we, the hospital team, anesthesia, even myself, we all agreed that we needed to test this patient for drug use, and they denied it, and it came back with, I think, positive for cocaine and amphetamines or something, and the patient got canceled. So, I mean, that's just dangerous going into anesthesia, though especially cocaine. But, again, we really want to make sure you get through this safely. So related to this, there's also a slide I put in there about people with like opioid abuse history. That in itself does not exclude from having surgery. Okay, so don't be like, oh, I used to use, but now I don't, I'm going to get turned away. That's not true. I've done surgery in many patients who have that history, but they're clean now. And so, so don't think that that's what it is. We want you to be in your best health going into this. Another sort of item in, being eligible for surgery is that you have a place to stay, right? You need a safe, supportive environment to be in going into surgery. And I know that it can be very, very hard for some of our sisters out there. And so, there are resources, we can help with that. But, what we don't want to do is do something, again, as complex as vaginoplasty and have the patient not have a safe place to recover in, but also because of the dilation, you really, really need a safe space to be able to do that. And because of its frequency, it does require a lot. There have been cases, not just through my previous practice, but other gender centers where they find out that their patient's living out of the car, kind of situation. And that's not, and I realize it can be really, really, really hard, and it's very unfortunate, but that's not how you kind of go into surgery. And so anyway, so that's also part of the eligibility. And actually at the hospital, me having been through as a patient, they do ask you these questions at the hospital as well, that to make sure that and this is not just our patients, it's everybody, right? So it's not like, oh, they're picking on the trans or non-binary patients. No, they ask it on anybody. And so so that's another factor to consider. And again, there are resources. So I think that's most of it, really. Oh, one more thing. And so, and I guess this part may be kind of a bit sensitive, I suppose, but I did end up putting it on my slide, and I'll talk now, is that it's basically the sort of the behavior and the interaction of patients, not just with me, but also with staff, hospital staff, but certainly the doctor's office staff, right? It's not just my office per se, but any office. I guess what I'm saying is, I mean, honestly, whatever's going on, we're trying to help as best as possible, but, do your best not to lash out at us, right? And so I say that I know that it's a very few minority, but it is an issue. And so unfortunately, such things have led to patients being dismissed, not just from my practice, but also GCC, but it's no different at other practices too. Just as an example, I'm not even gonna talk about my gender patients. Prior to this, I was doing regular plastic surgery, and it's no different. So, that I've had patients literally threaten, to come back and harm the hospital staff, and those things are taken very seriously. Or patients that, threaten to, in this part specific to our patients about hurting themselves, and we have to take this very, very seriously, obviously, and we wouldn't ever want that to happen, either one of these scenarios. But basically be a good, decent human being, be polite, be respectful, because people are trying to help you, and so don't become ineligible for something like this. Okay, so I know that can be kind of sensitive. But let's see, I have a list of things.
You had wanted to talk about weight too,
Oh,
right?
yeah, weight. So, okay, yeah, so weight. So there are different measures of weight and eligibility, especially when it comes to bottom surgery. I do have certain numbers, and I do use my just as general sort of measure, but that's just a number, right? It's not. BMI by itself isn't an indicator of good health. What I do tie into that is the body distribution, right? Where's the weight sort of coming from? Some people are very like top heavy, right? Big shoulders, big belly, and the fat tends to concentrate. As you can imagine, there are body types for all humans, right? There's different types of known sort of body types. And that's sort of genetic. There's a predisposition to it. And so sometimes, for example, sometimes the BMI might be on the high side, but then when you look at the patient, you realize that they really, truly are big boned, right? And they carry a lot of their weight up in the midsection or on top. And it's necessarily say morbid obesity or something like that. And then I look at their inner thighs, their pelvic region, and their legs, and they're pretty skinny. And so the reason for the weight when it comes to trans fem non-binary bottom surgery is that when there's a lot of tissue in that area, it makes it very hard for me to reach the depth to reach, or tissues. Once I open the area, it gets in the way, and so sort of when you think about it, it's like, oh, it doesn't look that bad, that's because our skin covering is kind of holding things together. But once you start taking things apart, things sort of bulge out of that area. And recently I've just been, we have these BMI requirements, and just I just don't want to compromise my level of skill, make the surgery harder than it should be, because I want to do my best doing the bottom surgery, and I don't want to have to struggle and basically, for lack of a better word, half-ass my procedure, right? My way of doing the surgery. And so again, it's, weight is a very sort of tough topic to discuss. There are places that are super, super strict, and it's kind of to the extreme. I feel like I'm kind of in the middle in terms of what my requirements are. So, and of course, depending on what procedure it is, the requirements are different, right? So, vaginoplasty versus plasty, it's a little more forgiving for vulvoplasty because I don't have to make the canal, which is the highest risk part of that procedure, because there are vital structures like the colon that can be injured if someone is not careful or, I guess trained enough to do it. So that's what we try to avoid. And most expert centers have very, very rates of those things occurring. So yeah, so that's the weight issue. Yeah, I think that sort of covers again, maybe not all of it, the admin type of requirements, but more of the clinical requirements or factors to be considered going into surgery.
Great. And could you talk a bit about electrolysis slash laser hair removal, what that looks like, how much you need to get done, or how much you need to wait afterwards to be confirmed good to go?
Yeah, so electrolysis, I don't require electrolysis for a vulvoplasty, okay? Because any hair that's in the area is easily reachable by any electrologist. For vaginoplasty, since for me, who uses skin line vaginoplasties, right? If you're having tunica vaginalis type of lining, you don't need electrolysis. If you're having peritoneal pull through, typically you don't need electrolysis prior because they're hoping to line the whole canal with that type of tissue. But since I use skin, scrotal skin, and if I don't have enough, I take it from the hip region. You don't want viable hair follicles, the root of it, to survive the process. Of course, that graft, like I said previously when I was talking about the smoking, that graft has to survive in this newly created canal. It's literally raw pelvic tissue, right? That I've made a canal through, spreading the different organs, of course. And so in the process of preparing that skin be used as a vaginal graft, I have to thin it quite a bit for it to survive. You can't just cut the skin out and put a big, thick chunk of it because it's not going to survive. Remember what I said about how graft survives, that it has to kind of go through osmosis? That's why grafts have to be so thin so that the oxygen gets to the tissue right away rather than having to traverse through a bunch of like subcutaneous tissue. Fat cells, the fat cell itself, small thin cell. It's big only because of the fat content of it, right? It's like a pouch for the fat. And so you can't just put a bunch of fat down from a thick piece and have that survive. So I thin it such that the most of the follicles that are remaining do get taken care of, but it's better to do electrolysis. I don't require it, but I highly, highly recommend it. It works for some people, but the one method that is considered permanent hair removal rather than reduction of hair is electrolysis, whereas laser, I think technically it's considered like hair reduction. And at one point in the past, I had to, for my own education and for a presentation, I was looking up, what the scientific evidence was, laser hair removal and electrolysis. And, it's from what I could gather, this little research thing of mine was that electrolysis was much more reliable in terms of permanence in hair removal. Now, having said that, this is the reality of it, right? You can say, oh, you need electrolysis of certain area, and our website does have a picture of sort of the general area that should be treated. But electrolysis places very widely in terms of how they do it, how much area they do at a time, how many sessions. And so even though someone has had, let's say, 9 months of electrolysis and they were cleared for surgery by their electrolysis person, I do the surgery, it looks pretty good, but 6 months, 9 months later, there's hair inside. It's usually, a little bit of hair is okay, but when a big patch of it, ultimately, it's not the most hygienic thing because things get caught in it, right? Lube. It is a skin-lined vagina, so, the skin sloughs just like anywhere else. And so, I guess what I'm saying is go to a known, reputable electrolysis place and know that they will do a thorough job of the electrolysis. Otherwise, and you can find on the internet, Reddit or something, people that went through electrolysis and now have a hair problem inside, a 5-6 inch vagina that is hard to take care of. So I do highly recommend it. And again, there is a bit of a responsibility on the patient side to have it done prior to. But yeah, that's a common question I get on my consultations.
Really helpful. Thank you. And kind of adding on top of that, someone asked, would electrolysis differ if you had an orchiectomy?
It does not, because sometimes the scrotum does shrink a little bit. Sometimes it shrinks a lot more. But either way, I try to use as much the scrotal skin as possible. And so that's where the hair is. So I don't think that an orchiectomy changes the requirement for a skin-lined inversion, vaginoplasty.
Sweet. Thank you. Really appreciate you providing kind of just the general information on eligibility. I do have some questions in the Q&A. Do you feel like you want to move on to the Q&A section?
Oh, yeah. I think those were
Great.
the main topics, regarding this.
Sweet. This person asked, is at-home IPL, I'm trying to figure out what IPL stands for. Is at-home IPL a viable solution for hair removal, or should they be focusing on electrolysis? And then my question adding on that, can you get laser hair removal first and then do electrolysis later?
Yes, I'm not sure about the IPL. It's some sort of laser, but what I do know, because I do own one of those home like light hair removal things. But going into like my surgery, I just went for electrolysis again because it's like the permanent solution. I do see the trend of people getting started with laser and then electrolysis. I in some way I don't quite get the reasoning behind that because again, laser is sort of reduction. You may zap it, but maybe you didn't permanently like kill the follicle. It might grow back. So why not just go for the electrolysis from the get-go? It'll save you time when you're not doing the laser first. And you know that you're getting like the, quote unquote permanent treatment, right? Which is electrolysis. That's my personal take on it.
Got it. Is there a maximum age for the surgery?
Like how old someone can be?
Mm-hmm.
No, there really isn't a maximum age for the older for the older patients. It's basically physiologic age, right? You have to be healthy. Most of us, once we get old, we're all human. As we get older, we do a lot more comorbidities. And just like I talked about with the comorbidities, they have to be controlled, right? So if you have coronary artery disease, that has to be controlled and cleared by the cardiologist prior to surgery. So I really look at physiologic age for that. But also in the older patients, I also look at neurological health, right? And so what I mean by that is that I certainly don't want to put a patient in the position of now they have to dilate it, but they are, sort of early stage dementia, or, they're forgetting things, so they may not remember or be able to do the dilation or take care of themselves better. I have taken care of patients who are older, post-op patients, whether they were my own patients or someone else's, that came or that I had to take care of, and it can be a real issue. So I think patient selection is very important in the older population, not just from the physical health part, but also the neurological, I guess, brain function of the patient. Not to say that old people are all demented, but that is a definite consideration. What's the oldest I performed surgery on? I think 69, maybe even actually 70 for vaginoplasty anyway, but they were very, very healthy, elderly patients. They did not have any issues with the post-op care, dilation, that kind of thing. Oh, the other thing too, if I may, I also, in terms of the comorbidities, physical disabilities, right? Patients who are in wheelchairs and things like that, not necessarily an absolute no to surgery. Of course, it has to go case by case as to what what that condition is, what's being treated. And sometimes it's not even something as sort of extreme as like, oh, they're wheelchair bound. Sometimes it's like back, neck issues. They literally can't get themselves in the position to do the dilation, right? So that's also a consideration in, eligibility for bottom surgery. Again, individual case by case. And these are all things that we do look at and consider, but not necessarily an exclusion depending on what it is.
Sweet. Thank you so much. This person asked, do surgeons ever quote unquote double down? For example, performing a different surgery in tandem with the vaginoplasty?
Yeah, combining surgeries is pretty common actually. All kinds of combinations. FFS, bottom surgery, breast dog vag or vulvoplasty, breast dog labiaplasty. Yeah, it can be done. It may not be able to be done all in one day, depending on how many procedures we're trying to like pile on. So my rule for patients who want to have one big recovery, I do 2 days of surgery, 2 days apart, typically.
Mm-hmm.
Does that make sense? So
That
I did
does make
full day
sense.
of surgery, and I strategically, again, depending on what the sets of surgeries are, I strategic like plan day one. These are the procedures I want to do. And it usually involves the vaginoplasty first or the vulvoplasty as part of the first day of surgery. And then, they stay in the hospital, and then 2 days later, they're back in the operating room for the remainder of the procedures. But again, it just depends on that's like a full package sort of person. But yeah, I mean, that can be done safely.
That's great. Awesome. Someone asked, I had an abdominoplasty to remove excess abdominal skin after weight loss. However, they said that their penis is lifted as well. Does that make a difference when going for bottom surgery?
No, if anything, that's a positive because you don't have a penis hanging over and possibly making it hard for you to dilate. No, if your genitals have sort of shrunken or whatever, if I don't have, since I do skin line vaginoplasties, if I don't have enough tissue from the penile shaft in the scrotum, I don't hesitate to go to the groin crease hip area to get more tissue. Sometimes I only need skin from one groin piece. Sometimes it's both sides. And I do, even though I take a patch of skin, and it's just the skin. I don't carve out a huge like channel. It's just skin. I just take off the skin, and it gets close, and it's just one long line. Typically about, well, it really depends on how much skin I need. Typically about 6 to 9 inches, again depending on how much skin I need, and it tends to heal very well, and it can be hidden if you're sort of conscious of what type of like bikini you wear, because you can put the side strap over your scar if it's something that you're concerned about.
Great. Someone asked, what depth is possible with shallow depth vaginoplasty that doesn't require dilation?
That's a good question. So usually with a vulvoplasty, it goes by all kinds of names, right? Shallow dimple vaginoplasty. I typically make it so that it's about an inch deep, but of course that depends on the patient's weight. Heavier patients sometimes end up with kind of a perceived deeper dimple, only because there's a lot more subcutaneous tissue around the vulva, whereas the true sort of like pelvic dimple is the same. It's still an inch. It's just that there's a lot more tissue. Now, the reason why I don't go like much deeper than that is that for vulvoplasty, I'd say, if someone wants 3 inches and they don't want to dilate, chances are the 3 inches over time without dilation ends up being, 1.5 inches. You're back to like a standard dimple vaginoplasty. So I tend not to do it because of that reason of like, oh, let's just do halfway, right? Typically it's 5 to 6 inches. So I try not to do like 3 inches only, unless the patient's dilate 3 inches, and it's fine if that's what you want. I might have done it once a long time ago because the patient didn't want extra grafts. They didn't have enough tissue, but they had just enough for about 3 inches, and they dilated. So hopefully they maintained it and they kept the 3 inches. But yeah, I think that's really the only time. That's why I remember it, because there was just one person that wanted that, had agreed to it. The other thing is the risk. The vulvoplasty, because I'm not digging a canal, the risk of injuring the rectum and creating a fistula is virtually zero. And luckily, I don't have wood to knock on, but luckily that has been the case with vulvoplasty. Now with vaginoplasty, my rate is very low. Anyway, it's less than 1% for injury to urethra or but the risk is there each and every time I do it because I do have to dig quite a deep canal, right? 5 to 6 inches of canal. But with a vulvoplasty, I, I feel like it's virtually zero risk if I just stick to the 1 inch.
Cool. Thank you so much.
Yeah.
This is a question that I'll actually pass over to Rosie.
Okay.
This person asks, how do you start the process? Do you have to find someone to do the surgery first, or would it be better to reach out to get letters and or confirmation of whether insurance will cover it first? There's that question, if you want to answer that. And then there's also kind of just the overall patient journey, if you could kind of give a timeline of what that generally looks like from kind of start to finish.
Yeah, for that person's question, I think that really depends on, a lot of people will find somebody to do their surgery first and sort of figure out who the best match is in terms of a surgeon. For the insurance part and the letters part, you would have to make sure that, wherever you're going for surgery will take your insurance, verify that your insurance will cover it as well. Some insurances don't provide gender benefits, unfortunately. So either, I would say either you would find your surgeon and figure out the best way to go to that surgeon for care, what insurances they take, and then figure out the letter requirements from there. Or you could go based off of whatever your insurance is at the time, see if they have a list of surgeons that perform that procedure that you could go to. And then in terms of general patient journey, at least at the GCC, you can call in or you can fill out a form on our website and we'll provide more information. Usually we will verify your benefits, so we'll make sure that your insurance has coverage and that we are able to proceed through your insurance. We take the majority of commercial plans and we also take managed Medi-Cal plans. We do our best with a lot of Medicaid plans, but sometimes those are a little bit trickier. We do require our letters of support for insurance prior to consultation because our consultations are free. That also means that usually you have a really fast process to surgery after your consultation. So after you've talked to one of our surgeons, determined your surgical plan, we're able to get you on the schedule quite quickly, depending on, medical clearances as well as insurance processing times. And then from that point on, it's all kind of clinical. So you talk to our physician assistants about your medical history, talk to your surgeon or their clinical team a couple more times to make sure the surgical plan is good. And then, take it from there.
Great. Thank you so much, Rosie. Back to Dr. Lay. We have just a few more questions. One person asks, beyond vaginoplasty and vulvoplasty, are there any physiological-based procedures that repurpose the, what they say, sexually dimorphic structures?
What structures are they talking about?
I'm not sure, Heather. If you want to clarify that in the chat, that would be amazing. But while we're waiting for the clarification for that, this person asks, I'm curious if you can describe sort of where in the new vagina the donor tissue from the penis will be located. They're just trying to imagine where the nerve endings will end up moving.
Yes. And so for the penile inversion, the penile portion is always the one closest to the entrance of the vagina, if that makes sense. It is very rare for me to encounter someone that has so much penile shaft skin that it lines a whole 6-inch vagina. That's maybe happened. I've only seen that maybe 2 or 3 times, but that's very, very rare. But that skin obviously is still intact, right? It's still connected to the body. It hasn't been taken off as a graft. That's where that sensation would be, right on the side of the entrance. And of course, it depends on the pelvic anatomy, the how much shaft skin there is. It can line again, depending on how much tissue there is, it can line just the entrance, it can line not even the entrance, or it can line, half to 3/4 of the way into the 6 inches of the neovagina. And then the scrotal skin or the hip takes care of the rest of the depth.
That's great. Thank you. And another person asked, how long is recovery generally after surgery?
For vaginoplasty and vulvoplasty, most patients take off a month off from work, but I feel like 4 to 6 weeks is a general recovery period. Getting back to daily activities, I think that after 2 weeks, you're doing pretty good. You're pretty self-sufficient, meaning like you can go shopping, you can make your own meals at home, that kind of thing. You can do your laundry, but you're just not lifting heavy items, at once anyway. So I'd say 2 weeks, you're pretty comfortable. But yeah, most people take off 4 to 6 weeks. And of course, that depends on how much sort of sick leave or disability, sort of, whatever from work that you may have. And some people go back as early as 2 weeks to work because that's what they have to do. And of course, it depends on your job, right? So sort of physical, like labor type of jobs, it might take a bit longer for you to get back to full, your full employment. Cases you could go back earlier, but on like light duty rather than full duty. But light duty is a bit tricky because not every sort of job position has that option of light duty. Anyway, yeah.
For sure. Thank you. And going back to Heather's question, they had said, for example, prenatal tissues that throughout the course of the development deviate into male structures or female structures. This is around the question around if there's any physiological based procedures that repurpose these structures.
Okay, I think I kind of understand that question. Yes, we, as humans, we all sort of start off, with two cells forming into, a full human, right? So any of the structures can be traced to certain origins. Course, at some point it diverges, right? It turns into like what's considered male genitals to female genitals, and then not to dismiss the ones that are intersex, right? Where things sort of mesh and then, a different sort of presentation comes along. But I think that once the tissues are, again, fully formed and differentiated into what they're going to be, I don't think that there's, I mean, I guess I still don't understand the question because things do differentiate into whatever anatomical structures folks have as a fully formed human. And so, like the prostates, trans women are going to have prostates and nobody takes them out to gender surgery, right? It's too risky. It's just too much surgery. It's unnecessary, that kind of thing. Seminal vesicles, no one takes those out either. You got to really dig to try to find them. And it's completely unnecessary. So no, I'm sorry. I guess I still don't understand the question. But things are repurposed, right? The clitoris turns into like the glands of the penis turns into the clitoris. And it serves the same function as it was intended to. The urethra, of course, gets shortened, so it becomes a urethra. The vagina, of course, it's sort of, quote unquote artificial, right? We haven't solved that problem in terms of making it really match.
Person put in, for example, converting a prostate into a skin gland.
No, nobody does that.
For sure.
But here's the thing about things like that. Glands, like I mentioned, the seminal vesicles, yes, it is a quote unquote male structure, but postoperatively, that actually goes in favor of including the prostate because it should still function. And so I think a certain percentage of patients still, when aroused, sort of that what's considered pre-cum, right? Like the clear, slippery fluid. And so I feel like that's kind of a plus. Now, post-op ejaculation, right? That is something that is talked about. And that's an actual thing. Of course, semen doesn't come out because that's a lot of the content of semen is made by the testicle and the seminal, not the and the epididymis. So with that gone, that's why that's the ejaculation of a post-op, feminine person isn't like white creamy, right, like semen is. It's just clear fluid, and a lot of that is seminal vesicle fluid and prostate fluid. So again, I sort of see that as a plus. And not everybody is able to ejaculate or even have like the pre-cum with arousal. It really just depends on the person. But yeah.
Sure.
I'm sorry if that still didn't address the question, but yeah.
No worries at all.
Yeah.
Yeah. And I know that it is time for you. There is one more if you want to answer it real quick. I
Sure.
also want to be respectful of your time, though.
No, sure, go ahead.
Well, someone asked if you had prostate cancer and had surgery to remove that, is that an issue for getting bottom surgery?
That is an issue. That is an issue in terms of sort of that has occurred from the prostatectomy. I think nowadays, I think that used to be a bigger issue in the past when it was like traditional prostatectomy, but now they do it all fancy with the robot and they go from the inside, right? And so like when I learned to do this, anybody who has had a prostatectomy, we would only offer them a vulvoplasty because that way we're not to get through a very scarred surgical plane. Now, when I create the neovagina, it's literally skates right on top of the rectum, right? And that's the normal anatomical position for a vagina. But on the upside, right, that's the bottom side. On the upside, of course, the urethra's there. And then the prostate, for those who have a prostate, those who have had prostatectomy, that's all scar tissue, regardless of whether it was done from the bottom or the top. Although, like I said, I think the robotic is less traumatic and probably causes, it's better healing and a lot of benefits for that. And so I would say that if someone has had a prostatectomy, I'd probably still offer them a vulvoplasty rather than risk injuring the bladder, the urethra, or certainly the rectum in doing the surgery.
Awesome. Well, thank you so much, Dr. Lay. Thank you so much, Rosie, for all of your just like expertise and knowledge and education. Super, super helpful. I know that it is time, and so I'm going to move us quickly into the outro, but also if you do need to leave, Dr. Lay, that is also totally fine too right now.
All right. I will provide the slide deck so that you can refer back to it and look at sort of, all those topics.
Mm-hmm. Great. And yeah, and kind of maybe while you're heading out to this last one is for Rosie, how would one look into seeing if their insurance covers any gender affirming surgeries?
Yeah, that's a really good question. Usually I would tell patients to call member services. There's a number on the back of their insurance card and just see just ask them if they have gender benefits. Our office will also look into that for you. We'll look into whether or not you have gender benefits. We'll look into common codes that we use for the surgeries that we perform. And we look into whether or not our providers are in network with your insurance so we can have a more bigger picture of like what it looks like to get your insurance to cover procedures with us.
Perfect. Thank you so much, Rosie, for that. Kind of moving us towards the outro. So this is with the Gender Confirmation Center. They are based in San Francisco, California, in the Bay Area. If you're looking for any kind of consultations, any surgeries from them, here is the website that you can click. It's genderconfirmation.com. Like Rosie said, their consultations are free. And so if you're looking for surgery and you're kind of worried about the cost, this is kind of the way to go, honestly. But Rosie, is there anything else that you kind of want to add to that before I move us towards closing?
You're free to call in if you'd like. Numbers on the website. We're very friendly. We're very welcoming to any questions you may have. We know insurance is really daunting, so we're definitely here to help and hold you through trying to get coverage for that. And if not, we have resources for tons of different ways to, help you get to your goals.